Cervical radiculopathy is a condition frequently encountered in clinical practice, yet it remains a diagnostic challenge for many healthcare professionals. The prevalence varies with rates influenced by diagnostic criteria, geography, and occupational factors. Despite its common occurrence, the understanding of cervical radiculopathy is still evolving, and definitions differ across guidelines. This video will guide you through the latest research on neurological examination for cervical radiculopathy, focusing on diagnostic accuracy, standard components, and current challenges in clinical practice. Let's begin by exploring why a clear and accurate diagnosis is so important for patient outcomes. According to the International Association for the Study of Pain, cervical radiculopathy is defined not by pain or symptoms alone, but by the loss of sensory and/or motor function due to slowed or blocked action potentials in a spinal nerve or its roots. This is a crucial distinction, as pain and paresthesia may indicate nerve irritation but do not necessarily confirm radiculopathy. Understanding this definition helps clinicians avoid misdiagnosis and ensures that treatment targets the underlying nerve dysfunction rather than just the symptoms. Lack of universally accepted diagnostic criteria for cervical radiculopathy increases the risk of misdiagnosis and inappropriate treatment. This can lead to delayed recovery and poor health outcomes for patients. Many researchers emphasize the need for consensus in diagnosing this condition. Accurate diagnosis is not just about labeling the disease, it's about guiding effective management and improving patient quality of life. Let's look at how neurological examination fits into this process. Bedside neurological examination, B&E, is a cornerstone in diagnosing cervical radiculopathy. It involves assessing peripheral sensory responses, motor function, and tendon reflexes. According to recommendations, the B&E should focus on identifying loss of nerve function, which is the hallmark of radiculopathy. However, the exact components and procedures of the B&E can vary widely between clinicians and studies, leading to inconsistencies in diagnosis. Given the uncertainties surrounding the diagnostic accuracy and standardization of the neurological examination, a recent scoping review set out to map existing research. The main goals were to evaluate the diagnostic accuracy, identify key components, and assess the performance of the neurological examination for cervical radiculopathy. This review aimed to fill knowledge gaps and provide direction for future research in clinical practice. Review followed a rigorous methodology, searching multiple databases including PubMed, EMBUS, Scopus, Sinhal, and DITA up to early 2024. Studies were included if they reported on the diagnostic accuracy or performance of at least one component of the neurological examination for cervical radiculopathy. Both cross-sectional and controlled studies were considered, with no restrictions on time, location, or language. This comprehensive approach ensured that the review captured a wide range of evidence. Out of over 12,000 records initially identified, only 6 articles met the strict inclusion criteria. All included studies were cross-sectional and compared the neurological examination with either electrodiagnostic tests or MRI. Data extraction was performed independently by 2 reviewers, ensuring objectivity and reliability. Studies varied in their patient populations, examiners, and reference standards, reflecting the real-world diversity in clinical practice. Neurological examination for cervical radiculopathy typically includes testing somatosensation, such as light touch and pinprick, muscle strength, and tendon reflexes. However, the exact procedures and reference standards used in studies were often poorly described or inconsistent. Only a few studies detailed how each component was tested, highlighting a need for standardized protocols in both research and clinical settings. Reference standards for diagnosing cervical radiculopathy in the included studies were highly heterogeneous. 4 studies used electrodiagnostic tests like EMG and nerve conduction studies, while 2 relied on MRI. Each reference standard has its own limitations. Electrodiagnostics focus on large fibers and may miss small fiber involvement, while MRI detects structural changes but not necessarily functional deficit. This variability affects the interpretation of diagnostic accuracy results. Tendon reflex testing was found to have high specificity but low sensitivity for cervical radiculopathy. This means that while a reduced tendon reflex is quite specific for the condition, many patients with radiculopathy may not show this sign. For example, specificity ranged from 81% to 99%, but sensitivity was often below 30%. Reflex testing is less influenced by patient interpretation or pain, making it a more objective component of the exam. Sensory testing, including light touch and pinprick, showed low sensitivity but moderate specificity. Sensitivity ranged from 25% to 52%, while specificity was between 46% and 89%. The variability in dermatome maps and overlap between individuals can make sensory testing less reliable. Combining different sensory modalities such as light touch and pinprick can improve sensitivity but may still miss many cases. Muscle strength testing demonstrated low to moderate sensitivity and moderate to high specificity. Sensitivity ranged from 24% to 81%, while specificity was between 61% and 94%. Muscle testing can help localize the affected nerve root, especially when severe weakness is present. However, results may be influenced by pain or patient effort, and the choice of muscles tested varies across studies. Binding 2 or more components of the neurological examination, such as sensory loss with tendon reflex deficit or muscle weakness, increases specificity but often lowers sensitivity. For example, the combination of tendon reflex deficit and sensory loss reached specificity as high as 99%, but sensitivity remained low. This means that while positive findings are highly suggestive of cervical radiculopathy, negative findings do not rule it out. Major challenge identified in the review is the lack of standardized procedures for the neurological examination. Key muscles, reflexes, and sensory tests varied between studies, and reporting was often vague. This inconsistency makes it difficult to compare results across studies and limits the generalizability of findings. Establishing clear protocols is essential for improving diagnostic accuracy and research quality. Both MRI and electrodiagnostic tests have limitations as reference standards for cervical radiculopathy. MRI detects structural abnormalities but may not reflect functional nerve impairment. Electrodiagnostic tests focus on large fibers and may miss small fiber involvement. These limitations can lead to false positives or negatives, affecting the perceived accuracy of the neurological examination. Similar challenges exist in diagnosing lumbar radiculopathy. Studies have found that neurological examination for lumbar radiculopathy also shows variable sensitivity and specificity, depending on the component tested. This highlights the broader issue of needing better reference standards and standardized examination protocols for all types of radiculopathy. Despite its limitations, the neurological examination remains a vital part of the initial assessment for suspected cervical radiculopathy. High specificity means that positive findings can increase the likelihood of diagnosis, but low sensitivity means clinicians should not rely on a negative exam to rule out the condition. Combining exam findings with imaging and electrodiagnostics can help guide management decisions. Review highlights the need for future studies with rigorous methodology, larger sample sizes, and standardized protocols. Researchers should aim to use valid and reliable reference standards and provide detailed reporting of examination procedures. This will help build a stronger evidence base and improve the clinical utility of the neurological examination for cervical radiculopathy. Summarize: the neurological examination for cervical radiculopathy has high specificity but low sensitivity. Tendon reflexes are the most specific component, while sensory and muscle testing are less sensitive. The lack of standardized procedures and reference standards remains a major challenge. Clinicians should interpret exam findings in the context of the overall clinical picture and use additional tests as needed. Bedside neurological examination is an essential tool in the diagnostic workup of cervical radiculopathy. While it has limitations, especially regarding sensitivity, it provides valuable information when interpreted alongside imaging and electrodiagnostic studies. Moving forward, consensus on definitions, reference standards, and examination protocols will be key to improving diagnosis and patient care. As research continues to evolve, clinicians and researchers must work together to refine diagnostic criteria and examination techniques for cervical radiculopathy. By addressing current gaps and standardizing practice, we can enhance diagnostic accuracy and ultimately improve outcomes for patients suffering from this challenging condition. Thank you for joining us on this comprehensive overview of the neurological examination for cervical radiculopathy.